Thank you. What a great introduction. Again, thank you to IOM for allowing us to come.
There you go. Click yeah.
Thank you. Once again, thank you for allowing us to come and tell Ohio's story. Because I'm from a small town, and you saw an example of one of my patients, I'm the reality check on the ground. So I'm indebted to my state governor's office for allowing a small town pediatrician to be part of the conversation. And I think that's part of what we need to do, is it's not just about concept. How do we get to real action that matters to real people who might be you or your neighbors or your relatives? So what I'd like to talk about is, it's not about new money. What Dr. Wimslow and I have in common is what do we do within the constraints that we have, which is no new money. So it is about reorganizing. It's about putting all our cards on the table and figuring out how do we play a different game. Not how do we steal cards from someone else and game the system, but how do we actually really do a better job? The system was actually designed to pay for ill care. And so what we've realized over these decades is the health of our population is going down because we're paying for ill care. And now we're sort of scrambling because healthcare costs are escalating because people really are not healthy. So how do we get from this to where we want to be? In the end, my name's Mary Alignment Applegate. It is about aligning, and it's easier if it's on the front end. So as we talk about collaboration, the planning process is really, really important to establish where the common ground is and hang on to those ropes as we get to the value-based purchasing conversation so that we can get to win-win. Now, what that requires is if you're doing something that's not as effective, you must stop doing what's not as effective so that you can do more of what works. As simple as that sounds, this is a reason collaboration doesn't work, especially if you're in a grant-funded environment. You have to do stuff through the duration of your grant, and then you have to apply for another grant so you can figure out if what you did before really worked. And we have this fascinating cycle that to the person is meaningless. So if you say, I can only help you this time because my grant runs out in the next 2 years, so sorry, I can't help you for your next baby. I mean, how does that seem to the person? How does that actually seem to Europe and other countries, third world countries, who actually do a whole lot better on a number of health fronts? So what this is about is, number one, we, which means together. We have some basic understanding, and then we align and find the common ground. And then with that understanding, we actually design, we identify the design elements that are necessary ingredients for the outcomes that we want. And I would argue that we're actually still in these rudimentary stages in lots of fronts as it relates to population health. The next piece then is to really get down to detail and develop the plan and then implement the plan. So in places that we've figured out alignment and measurement systems, we never get to the implementing of the plan. Partly because there's not enough focus. So 64 measures, however many measures you have, if you ask somebody, can you do these 64 things? No, they're at the bottom of the to-do list. So really, people can take on about five or six big topics, population priorities, and they can really work that out. If you give them 64, something is not going to happen. So I think we should recognize that as systems and as people, we don't have endless priorities. We really do need to focus. So that's part of my circle there, is let's bring some focus. The next piece is the measurement strategies with all of our fantastic and world-renowned stewards has plenty of gaps and plenty of, I'll call them, cylinders of excellence, silos. And they're all quite excellent. However, we all need the same cylinder of excellence if we're actually going to move forward as a country, not just as a state, but as a country. So the next piece of it is, where is there evidence that there is a path that can lead to improvement? So we should be beyond trial and error. So IHI, I think, has demonstrated there is a more reliable way to get better if we actually harness what we know about science, which really has a data measurement and feedback infrastructure. The current payment system has no data feedback infrastructure. So a lot of the work that Dr. Wimslow talked about is about organizing yourself in a way that you can get the information you need to go looking for the people who don't just show up. So that's the next piece. And then this next line is, it's all in the context of kind of the greater public good and also your socio-political systems. So political will is an amazing engine, an absolute amazing engine So as clinicians, if we're up in arms, that does not get you to collaboration, even if our disparities in outcomes are egregious. If you're angry and shouting, it makes it hard for other people to listen. So we have to find a very collegial way to have a conversation, to have the right people at the table, and to really bring ideas that we think are actionable. And then that gets us to this last line. In the end, when Dr. Winslow tried to talk to all these practices, guess what the question was? Where's the money? Right? Isn't that what you got? Where's the money? It's very important that you proceed through these steps, which just, by the way, look a little bit like a population triangle. You have to have the design elements and then figure out how to pay for that. So that's actually the value. So what folks generally want is, where's the money, and then chase it. So I think we have learned that that strategy is not effective at all. So in Ohio, I'm actually happy to say that we are following a process that we think actually will get us there. So you referenced this already. Here's the slide that shows our healthcare expenditures in Ohio. And it shows that Ohioans spend more per person on healthcare than all but 17 states. And these states are actually ranked according to the health of the people. So we have perhaps the least healthy people at the highest cost. So I can't sell that. I can't say, hey folks, come to Ohio. It's the best place to have your business and raise your family and enjoy the great winters when there's no good financial case. So we do have to acknowledge what the issues are, and this was really the impetus for reform. So it's not just the extension of the Medicaid benefit. It actually is leveraging the authorities that exist in public health and Medicaid and other state entities to get to a better outcome. So to that end, this is perhaps the most important slide. This is about collaboration, which is a little different from cooperation. People who are cooperating often don't have the same end game, but part of the journey is together. So we'd like cooperation even if you're going someplace different. And then in the end, coordination, which is all about communication. So a little alliteration here. That's really what we're trying to do. And this is very, very difficult because it slows down the process. We have to make sure we can hear and listen appropriately. And so sometimes, how long do you listen to things before you try to nail down the plan? So there's tension within the system, because if you go too fast, we haven't listened. If you go too slowly, you never get to action. So we have tension at multiple levels related to collaboration. So what I see, just coming from a small town and kind of being part of the fabric of our community, is we have a whole bunch of work at the microsystem level that is not connected to each other. So for example, we do lots of home visits, but the home visiting person is not connected to either I'll use the maternal child example. It's not necessarily connected to the pediatrician nor to the OB. So for decades of home visits, we have not improved postpartum visit rates nor the reproductive health content at all for the Medicaid population, at all, zero. So millions and millions of dollars of investment, and we haven't made it to move a measure. And why would that be? Well, it's an entirely different system, and they have to measure different things and report them to different entities. So the opportunity that I think stands before us is there a way we can get our programs together for a common purpose? So I would argue, I'm going to use a maternal child example just because infant mortality is a crisis in our country. I would argue that sweet spots exist around what public health officials call preconception health, but what the average person might consider to be adolescent and well woman wellness. There's a sweet spot there. And ACA is absolutely, the Affordability Act is an absolute game changer, because the role of public health is no longer safety net services for everybody who's uninsured. There'll always be some of that, yes. However, women and families now have the possibility of actually getting care, getting access to care. So what does that mean we can do? We can do a lot of different things now. So adolescents actually might be able to be seen. We can then work on the content. And then in the postpartum arena, that actually is an important measure for Dr. Liu and all of HRSA. It's an important measure for all of the clinicians and health systems. It's an important measure in terms of interconception care and the identification of high-risk women. So we actually can get someplace to change our preterm birth and our infant mortality numbers, because the measurement system is the same, because it's aligned. And by the way, The HEDIS measure is something that private industry uses. So we have the possibility of even knowing what's going on in each of our states. So that microsystem level at the community level is not necessarily aligned, communicated with same measures, and there are legal reasons. FERPA, one of my favorite ones in the school system. You're not allowed to track a student and tell anybody what's going on or who you're worried about. And could we impact suicide rates if we were allowed some communication? So in my small town, I can tell you, absolutely. We absolutely can help people, which means that the lawyers need to be at the table as well. So it's not just the health system, it's not just the politicians, it's the community advocates, it's legal rights representatives, it's folks who are connected to cultural competencies. So the next piece is at this mesosystem is a health system or a hospital, potentially a managed care plan. So all of the little docs and health clinics at the bottom are always mad at them. You're making us do this, you're making us do that. Well, that's because their contracts say that they have to do different things. So in the end, at this macro system is where we are as a state and as a country. So it would be very helpful if we had both a top-down and a bottom-up strategy that actually matched. So can we identify that for priority populations and then ask everybody to participate in activities that move known measures? And then, can these measures be made public on a rolling monthly basis so people know how they're doing as they go, much like your speedometer, so that you're not surprised after you have 10 tickets that year that, gee, you were speeding the entire year. So just to use an analogy that people can relate to, can we get to that in the healthcare system, realizing it's competitive and there are market forces and a huge variety of payers? So in the end, this is actually what we need to do. I have a few other comments here related to the measurement system, but in the end, that's the main take-home point. So what I have here is another pyramid. And what you see here is some discussion about a shift from the current fee-for-service where I pay for a procedure. Remember, we have a system that actually is designed to pay an ill claim. You need your appendix out, we pay for that. To how do you take care of the population? So on the hospital side, that might be considered an episode. I think many of you are familiar with that. And then at the very bottom is population-based. So we see the acute care hospital episode to extend beyond just what happens in the hospital, to extend and dovetail into the patient-centered medical types of environments that Dr. Winslow described. The fee-for-service piece really is good for discrete services that actually may improve outcomes or be available at a lower cost. Birthing centers, for example, could be part of that. The episode base would be most inpatient stays, asthma, emphysema. The newborn delivery is a good example, and that's the example I'll talk about in just a little bit. And then at the population level, this is where the care for the chronic conditions exists. It's longitudinal, but it must dovetail with the hospital episode. So for example, as we try to pay differently for care, if your primary care doc has walk-in hours, everybody has an asthma plan, the red, yellow, green plan where you know what to do if you catch a cold, really what will happen is you will have fewer hospital episodes. Now, the hospitals might not be too happy about that. So when we're at our mesosystem level, we must be measuring and counting the number of episodes so that we ensure that there's direct connectivity and not just I'll do all my own follow-up myself and then send them 10 counties away where they live. So what you can see here in this example is as we pay for fee-for-service, look at all the other people we're missing. This is actually one of the reasons we do not have good outcomes, is we're only counting the people who show up to our system. We're not counting everybody unless we're using vital stats or after somebody died. And so I would submit that we can do better than that. So you can tell I'm a pediatrician. We like drawings. So what I have here is, how have we created a system? So the payment system really was not a system. It was a little widget of that, a little widget of that, and if we have 12 of them, maybe that's enough to call it a pie. And that actually does not work. So you have the population pyramid here on the left, and the base of that is really important. It's all about the base. It's about not just physical health, it's mental, emotional health, behavioral health. It's about social circumstances and about education. So what other countries do better is they invest more for every person there at the base so that they have fewer people in this yellow, higher risk identification bucket. So all of you are aware of the impact pyramid. The more needs you have, the more things you throw at people, the less effective they are, and the more it costs. So if you have an illness-based system, your costs are huge with ever-diminishing returns. So the suggestion here is now we have a system under ACA, and you can think about this as 4 relay runners in a race. Nobody wins unless that baton gets across the finish line. So the first one is healthcare coverage. First runner is off to a good start in lots of states. The next one is, let's use our data in a way that actually is smart. So for example, in Ohio, we SAS-coded, computer programmed every cell in a birth certificate, and then clumped women into risk buckets, one for preterm birth, one for mental health and substance use, and one for chronic conditions. And on a monthly basis, we give that to the managed care plans, and then they have requirements for what they need to do for them. Now, granted, that's only an interconception care plan, and we've got to do something on the front end, but it's certainly better than what we have now, which is not sufficient, let's say. If you identify who's in care management, because we have a national Medicare system, all the systems are set up for the Medicare patient. Are you diabetic, hypertensive, an amputation person, and now have a stroke? Yes, you're in care management, which means we have missed 100% of all the $3 million babies who are now on home ventilators and in very expensive care with poor quality of life for the next 60 years. So let's use data in a smart way. The next piece is, how do you make it real at the neighborhood level, at the local health district level? Well, we can geocode some of that information so everybody in my town knows there are going to be 15, okay, it's a small town, 15 babies who are going to die related to unsafe sleep. Find them and don't let that happen. So every mother that you're nice to, every grandparent you talk to, every Target you go to and talk to the manager because they're selling bumper pads, that all helps. All of that helps. So a real number to real people in real health systems. We've got to get to that level. This is also where you can address the disparate outcomes and issues of health equity. Smart information. So we have the first runner, the second runner, the third runner. We are almost there. And this is where things really start to unravel. Who's coordinating? Who's talking to whom? Who's tripping the other runner? Who crossed out of their lane? How many teams had 3 third leg runners and no last runners? Who's going the right direction? I mean, who turned around and went the wrong way? So in this last coordination piece is actually where we have perhaps the largest issues. I understand a little bit more about turf now. I thought that was something on a football field, but there's a lot of importance around ownership and being proud of the work we're doing. And actually, there's no victory until that baton crosses the finish line. So this is where some of the hardest work around collaboration happens. So who does it? So I've heard that it only takes one care coordinator. Well, I can tell you that if you're complicated, you need a medical coordinator on the whole medical and surgical and mental health side, but you really need a community coordinator. Housing, transportation, can you get your medications? Do you even understand your medications? And what about the weather? What about your children? You know, there are so many, what about not being able to read all those words? There are lots of issues. So many patients actually need 2 coordinators, but who talk to each other and are allowed to talk to each other. So what I find in the Medicaid program is sometimes I have individuals, they have 8 coordinators, and they've each decided what their little piece is, and they don't always talk to each other. So how does this work? So let's admit it. Let's organize our care. Let's understand who is at risk. You know, in my town, we have a Honda plant, and anybody in the Honda plant is allowed to shut down the entire line if there is a safety concern. Any single person, and it's okay. In the healthcare system, we don't necessarily know who's at risk, and not everybody's allowed to speak equally. So, you know, if you're the nurse's aide or if you're mopping the floor and you see a safety issue, you must be able to hit the alarm and not get in trouble for it. So we have to go to the neighborhoods, go to where the people are, right? We have to understand who's at risk and who's not, and how does that change your interaction with them. We have to directly reach out to people, have a little text for baby signal there. Can we use phones to have self-identification of risk that might be faster than going through the entire system, wherever it's public or private? I note here community workforce. We need to demedicalize some things. If 40% of expenditure is social determinants, we need folks from the neighborhoods who look like, talk like, relate to the people that we're trying to help. And then on the bottom here, I actually note the patient-centered medical home in the red house. I note hospital care as an anchor of lots of coordination. But you notice I also have a faith-based community here. We actually have to go to where people are, and people don't just hang out at hospitals and doctors' offices for fun. So how do we get the message out? I actually think we can be organized with our message, put it in sound bites that people understand, and then eventually get to the pyramid on the other side where more people are walking at parks and healthy and active. And that's success. That is the baton crossing the finish line. So in all of our work, whatever population of priority you're looking at, can you identify the forerunners and how the baton crosses the finish line? And then now what I'm going to talk about is when the baton crosses the finish line, how do we pay for that? Does that sound good so far? Okay. So Dr. Winslow talked a little bit about this related to the SIM application, the design part. So remember, a lot of emphasis on the design, having learned from engineers. And now we're actually on to the implementation part. So you already mentioned many of the items on this slide here, but this really is a public-private partnership. Our governor gathered the 5 largest payers in the state, along with Medicaid and the state employees' insurance, to do things the same way. The same way. Collaboration is really quite difficult. So we have to remember that many of the plans are national. So Ohio can't just say, hey, can you do it this way? So, and it comes down to little details. You know, if you want to do progesterone to prevent preterm birth, one way you can do it is there's a pill, Prometrium, but sometimes it's used for infertility in women of reproductive age. So there are edits in many of the plans that say you're not allowed to have that under any circumstances for women of reproductive age because we don't pay for infertility services. So how do you get around that? You know, we can't change the entire national plan just because Ohio is interested in a very specific effort around preterm birth. So it's a conversation. So at least we have everybody at the table to try to figure it out. And we all decide what island we're rowing to, and then we kind of figure it out as we go. So many, many stakeholders. So here's the 5-year plan. A lot of times folks want the 1-year plan, and what's the ROI, right? It's at least a 5-year plan, and perhaps it took 50 years at least to get to this point. It's going to take another 50 to really, really get to a new place. So what you see is the patient-centered medical homes on the left-hand side. Ohio was one of the states that actually has the Comprehensive Primary Care Initiative. We're learning a lot about collaboration with federal, state, and public and private partners. On the episode side, we actually designed 5 to 7 episodes, depending on how you count them, with the initial reports coming out here at the end of the first quarter. The goal would be that 50% of patients by year 3 are actually participating in this kind of value-based purchasing arrangement, and 80% within 5 years. So that builds on the work that Director Winslow has done at the Department of Health in terms of having patient-centered medical homes on that side. And then I understand that my work is to help develop the next 20 episodes and eventually 50 over the next couple of years. So that's the work at hand, and I'm going to describe actually what that meant. So first, what is an episode? Something has to trigger it, and I'm going to use a delivery. So right now, in many states, it's a fee-for-service delivery. Every prenatal visit, you get paid. For some insurers, you get paid right after delivery. And then, are we surprised, actually, that a whole bunch of people don't show up for the postpartum visit? We don't have people helping get the entire spectrum of care. And then many of the women see no value. You know, they've delivered the baby, and after that, it should be like easy and natural. So there's not complete understanding. So we identify the trigger, and then we back up to what should be included in ideal care. We identify who the main person is who can influence outcomes. And sometimes it's a hospital, sometimes it's, in this case, the obstetrician, and then sometimes, like in orthopedics, that actually is the orthopedist who is most likely to help that person return to normal function. Based on the ideal patient journey that we actually draw out as a process map, we then identify what are the quality metrics worth measuring. And to me, there should be fewer. If we're going to go for the outcome, I shouldn't have 25 measures for every single one. People are uncomfortable with that. They like having their measures. Then we actually do some risk adjustment, and that then becomes the episode. So in terms of how this works, this is retrospective. So everybody continues doing what they're doing as they go, and this is part of the collaboration. Change cannot be so instant that you could lose 50% of your providers out there. So there has to be this transition phase, and for us in Ohio, it is retrospective. So really what this is about is the patients get care, the docs and clinicians present their claims, and then after 12 months, we give them feedback on how they did according to the definition that they themselves actually set. Based on that, we then give them this graph that shows average cost of each episode, let's say a delivery, and then we put where they are in red so that they know how they compare to every other clinician who's participating around the state. And then based on that, if they're in the sweet spot, they're eligible for significant gain sharing. On the other hand, if they're in the red, then actually they're at risk. So we have this entire first year to actually help people understand what's going on. So I'll give you an example of what the graph would look like. So the important thing here is for 50% of the clinicians, there will be no change. They're in this gray area. Many of the docs would say, oh, my patients are sicker, right? They're definitely sicker, aren't they? So what we have here are the folks in the green and the blue. Those are folks who actually have patients who are in similar or sicker risk buckets, and actually they don't cost more. So if you're in the green here, you actually stand to gain significantly by your more holistic and comprehensive care. On the very left-hand side in the red, you'd be surprised. Look at the beginning, from the beginning to the end, it's up to 5-fold, depending on the episode, up to 5 and even 10-fold differences in costs of care. So for example, in one of the other states who did this, the orthopedists found that at one hospital, the hospital cost was twice what it was at another hospital, and they said, gee, now that they know that, could we have the same deal we're getting at the other hospital? So the hospital said, no. And so simply, their patients drove 10 miles to go to the other hospital so that they could provide what they thought was better care, which included, by the way, physical therapy before you ever had a joint replacement, which saves close to $1,000 per patient, and then includes this whole rehabilitation piece afterwards to get them back to work and functional. So it is a game changer, absolutely a game changer. This is an example of what the report cards look like. So instead of total public reporting, if you're a principal accountable entity, provider, you can go in on the website through our portal and actually look at how you are. And we were able to negotiate that every payer, public and private payer, has all the report cards look about the same. So everybody's system is set up about the same. So perhaps you're frightened, perhaps you're happy. That's the plan. I have a list here of our many partners in our state. So my question is, wherever you are in your organization, what can you do to help? Everybody can help. If there's time, I can give you a more granular example of what does this mean on the ground, but perhaps you'd like to ask questions first.